Assalamu alaikum. The long clinical consultation day. First scenario, Mrs. Jeannie, 38 years old lady, presented with back pain. Vitals are normal. Please take history, examine the patient, and address her consent. Ready, Dr. Asha?
Yes.
Okay, here you go.
Okay, hello. My name is Dr. Al Mahdi. I am doctor in medical ward today. Can I confirm I am talking to the Mrs. Jenny, 38 years old? Hello?
Yes, doctor. Sorry. Yes, doctor. I am Jenny, and I am 34-year-old.
Okay. Mrs. Jenny, we are here to ask you some questions and examine you and address your concern. That's okay with you?
Yes, doctor.
Okay. Can you tell me what brought you in clinic today?
Um, Doctor, the last 1 month I'm having some pain in my back,
Mm-hmm.
which which is troubling me a lot.
Mm-hmm.
Doctor, it started 1 month back. I was just uh, I was just doing some activity and I fell from the chair and then I got hurt on my back. I thought
Mm-hmm.
it is a kind of small thing. It will go off. I took some paracetamol for a few days. I thought it will go, but it didn't go. And then I feel it is continuously bothering me. Please help me, doctor.
Okay, I'm sorry for your suffering, Mrs. Jenny. Mrs. Jenny, regarding to the back pain, you tell me it started into the one month back. Am I right? Yes.
Yes,
Okay.
yes.
Do noted anything is worsening to the chest, worsening to the back pain, like the movement or rest?
Uh, I think whenever I do something, the back pain increases nowadays. It is
Is
there most of
increased?
the time, but it whenever I try to do some more activity, then it increases.
Okay. Can you tell me exactly where exactly the site of the pain?
So he's showing you the place in the lower back at around L1, L2 level.
Mm-hmm. Okay. Is it once it started? It was sudden or gradually?
Now, as I told you, doctor, it started after I have fallen from the chair
Mm-hmm.
1 month back. I thought it will go in 2 3 days, but it persisted. The pain persisted
Mm-hmm. You mean this the pain started after trauma? Yes, after the fall.
after I fall from a chair.
Uh-huh. Okay, 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 uh, okay. Do noted. Can you describe the exactly what the nature of the pain?
It is quite dull, doctor.
Quite dull. Does the pain go anywhere else?
Of late, I'm seeing that the it is going to my legs, doctor,
Mm-hmm.
as well.
Mm-hmm. Okay.
To my
Do you feel okay? Do you feel any history of weakness in both leg?
No, doctor, I don't feel any weakness, doctor.
Any history of abnormal sensation?
No, the pain goes sometimes, so sometimes it becomes whenever I walk upstairs, so sometimes pain goes, and then I need to sit, take rest.
Mm-hmm. Okay. Any problem into the control into the back passage and water work?
No, doctor.
Uh-huh. Any history into the foot drop?
No, doctor.
Mm-hmm. Okay. Do you noted any other any pain to the other parts into the your body?
No, doctor.
Okay. Okay. Do you noted any history of a change into the any history of high body temperature?
No, doctor.
What about your weight?
My weight is fine, doctor.
Any recently change in appetite?
No, doctor.
Any history of tiredness?
Um, no, doctor. So
Mm-hmm.
I have some thyroid problem for the last 5 years, doctor.
Mm-hmm.
So that was diagnosed when 5 years back. I was kind of more tired. So that time I have shown some doctor. So he diagnosed that I have some thyroid problem. So
Mm-hmm.
I'm taking thyroid medicine. So I don't feel tired now.
Okay. Can you tell me exactly what is the thyroid problem?
I have my thyroid gland was a little swollen. So doctor gave me this medicine, thyroxine,
Mm-hmm.
75 microgram. So that
Mm-hmm.
medicine I'm taking.
Okay. Are you still taking this medication?
Yes, I'm taking this medicine still.
Mm-hmm.
Regular.
Okay. Any bad effect, any side effect from this medication?
No, doctor.
Uh-huh. Okay. Now, any history of weather preference?
No, doctor. I'm okay now.
Mm-hmm. Okay. Any history of joint pain?
No, doctor.
Any history of morning stiffness?
Morning stiffness in the back? No, doctor.
Mm-hmm. Or any morning stiffness into the other joint?
No, doctor.
Any history of skin rash?
Uh, I have some white patches. You will see that some vitiligo kind of things. You can see in the acral vitiligo kind of things. But some have some white patches I have noticed for the last five
Uh-huh.
6 years on my hands.
White patch in both hand?
Yes, both hands, some fingers.
Uh-huh.
I have shown it to the doctors. He assured that it is not of much thing. It is only
Mm-hmm.
some more cosmetic things, but I'm enduring it, doctor.
Mm-hmm. May I have a look?
Yes, you see some acral vitiligo kind of patches.
Okay. Okay.
Yeah, it is
Any history?
diagnosed vitiligo.
But
It is diagnosed vitiligo.
yes. Okay. Any history into the other skin rash into the sun exposed area?
No, doctor.
Any history of pigmentation or spot?
N- No, doctor.
Uh-huh. Okay. Any history into the dryness into the eye or problem to the vision?
No, doctor.
Any history into the dryness into the mouth?
No, doctor.
Any history of and sorry for asking this question. Any dryness into the private area?
No, doctor.
Okay. Okay. Any history of tummy difficult to the swallowing?
No, doctor.
Any painful swallowing?
No, doctor. No,
Any
doctor.
tummy pain, tummy distension?
No, doctor. Not at present.
Okay. Any history into the change into the bowel habit?
No, not at present. I'm very particular about my food and all, doctor. So, I am very particular about my health because I have this thyroid problem.
Mm-hmm.
And, doctor, whenever I go out, I take some outside food, I develop some loose bowel. So, I'm very particular about my food and all. So, so a lot of times it happened. I went outside and then I developed tummy upset. I developed tummy pain. I developed some loose stool, loose
Mm-hmm.
motion. So
Okay.
nowadays I become very particular about my food.
Regarding when the last time you had loose motion?
Uh, 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 Around 1 year back
Mm-hmm.
when I traveled to my native, so in the road I have had something, and after that I had a stomach upset. I had a tummy pain, and then I have loose stool for a couple of days. Then it stopped on its own.
Mm-hmm. Regarding to the loose motion, is related to the certain type into the food, like pasta, like something like milk, like something like that.
I'm not very sure to be very frank, doctor, because I do not know whether it's any kind of foods. So any relation do you suspect? So it happens. It happens a lot of times. So nowadays I've become very particular about my food, doctor.
Uh-huh. Okay. You mean this the loose motion is not related to the certain type of the food? You are not sure about that.
I'm not very sure. You might be
Mm-hmm.
right, you might be wrong, but I'm not sure that I've never heard that it happens like that.
Okay. Is it bulky?
And my bowel habit is fine at present. When I control my diet, my bowel habits are fine. I do not
Mm-hmm.
have any
Okay.
problem with it.
Mm-hmm. Okay. Any history of pass into the blood into the back passage?
No, doctor.
Any history into the dark stool?
No, doctor.
What about your water work? Any problem to the change to the amount of frequency?
No, doctor.
Okay. Any history of coughing of blood?
No, doctor.
Any history to the chest pain?
No, doctor.
Any shortness into the breath?
No, doctor.
Any awareness of the heartbeat?
No, doctor.
Okay. Apart from the hypothyroid and vitiligo, any other medical condition I should aware of?
No, doctor.
Okay. Please, can you show me medication list?
Thyroxine, he's showing thyroxine tablet 75 microgram
Mm-hmm.
once daily.
Okay. Apart from that,
Nothing. He doesn't take
any
any other regular medicines. He
any
has
recent?
taken
Mm-hmm.
he has taken some paracetamol for the back pain of late for the last few months, last 1 month.
Okay. Any recently changed or added any dose of thyroxine?
No, doctor.
Okay. Any herbal medication?
No, doctor.
Any allergy from any medication?
No, doctor.
I am sorry for asking this question. Any party drug?
No, doctor.
Any history of surgery?
No, doctor.
Okay. Any history to the lumbar bump to the anywhere?
No, doctor.
Any family history of the same illness?
My mother also had a thyroid problem, doctor.
Mm-hmm. Okay. Okay. Any disease runs in family?
No, I know that
Mm-hmm.
my mother has this thyroid problem. Other than that, I am not very sure, doctor.
Okay. I'm really sorry about asking these questions, but may be related to the condition. What about your period? Is it regular?
Yes, doctor.
Are you using any pills?
No, doctor.
Are you sexual active?
Yes, I have my boyfriend, doctor.
I am really sorry about asking this question. Any extramarital relationship?
No, doctor.
Any history of surgery?
No, doctor.
What are you do for living?
I'm a teacher, doctor.
Okay. How much this symptom affect the job and daily activity?
I'm very irritated with my back pain, doctor. So I need to do a lot of activity, but this back pain is bothering me a lot.
Okay. I'm really sorry about that. I will refer to the occupation therapist, occupation department to help you regarding this the issue. Do you smoke?
I know, doctor.
Do you drink alcohol?
I drink. I drink sometimes, doctor. I cannot
Mm-hmm.
drink beer, doctor, because sometimes the beer gives me very stomach upset. So I do not drink beer. But sometimes I do. I can. I'm not very avid drinker, but socially sometimes I drink some gin or something.
Okay. How much you drink over the week?
I'm very minimal. I might be drinking probably once a month.
Mm-hmm. Okay. Okay. Can I examine you?
Yes, doctor, of course.
The first of all, the general look of the patient, the general surrounding. I want to check into the
Mm-hmm.
vital sign.
Mm-hmm.
I want to
Vitals are
examine.
normal.
Uh-huh. Okay. I want to examine the back if there is any deformity, if there is any tenderness.
Yeah, you can find some tenderness over L1 vertebra. Otherwise,
Uh-huh.
it's unremarkable.
Okay, I want to examine the general examination if there's any pallor, if there's any clubbing, if there's any cyanosis, if there's any pulmonary erythema. Uh-huh.
Uh, no
Uh,
pallor,
uh-huh.
nothing is there.
Okay. Any problem to the while combing to the hair or sitting up from the chair?
No, no,
Okay, I want to examine the eye, pallor and jaundice.
2 minutes
Uh,
left.
not feeling,
okay, I want
not
to examine,
feeling.
yes, the mouth of cyanosis, and I want to examine the abdomen if there's any tenderness.
No tenderness.
Okay, what's your concern?
Doctor, why I'm having this back pain?
Mm-hmm. Regarding to your symptom that you have, most probably you have a condition with the called osteoporosis, is the medical term for
Mhm.
the medical condition due to the thinning of the bone, may be related
Mhm.
into the condition that you have because may be related malabsorption disease, difficult to absorption to the some of the nutrient due to the loose
Mhm.
motion and due to the having to the condition uh, like problem to the gland and problem to the skin, vitiligo. What we need to do now, some blood test and imaging, and also I want to do the imaging to the your back. And
Mhm.
after that, I will refer it to the group specialist, including to the bone doctor and gut doctor and gland doctor, to provide into the proper management plan.
Will I get
The,
better, doctor?
yes. What?
Will I get better, doctor?
Depending into the depending into the investigation and depending to the imaging, I will arrange it to the other meeting to discuss with you about this condition can be is treatable but not curable, can be controlling by medication.
Okay, okay, doctor. Why does it happen, doctor? This you told some bone thinning. Why does it happen, doctor?
Yes, it's happened due to may have a condition is problem into the due to the problem to the absorption to the some nutrient from the your gut.
Mhm.
Um, uh-huh.
But I take so care of my health, doctor. Do I need some supplement, doctor?
Yes, because may needed into the some supplement and may be related into yes because into the some supplement yes because into the malabsorption to the some supplement needed into the need for health of the bone for that needing to the thing yes.
Time is up.
Okay,
Yeah,
Uh-huh.
thank you,
okay,
Dr.
doctor. Thank you, doctor.
Examiner questions.
Okay, so what is your positive physical finding, doctor?
The finding, physical finding regarding to the history and regarding to the examination.
Regarding to the examination.
Regarding to examination, the patient is presented with back tenderness into the lower back.
Mm-hmm.
Yes, and also I offer to do the lower limb examination. Mhm.
Okay,
Regarding to
okay.
the examination.
Mm-hmm.
Regarding to the history, the patient is presented with history into the lower back pain since into the 1 month. It started into the gradually and increase progress. Associated increase the patient association to the fatigue and past medical history into the hypothyroidism, which taken to the L-thyroxine and vitiligo and history into the loose motion and tummy pain.
Mm-hmm. Mm-hmm.
Uh-huh. And
Yes,
history
doctor.
into the family history into the hypothyroidism of the
And
gland problem. Mhm.
okay, any physical examination you would like to consider to do
Regarding to the
more?
physical examination,
Mm-hmm.
um, I want to check if there is any patient pallor, any lymphadenopathy, any mouth soreness.
That
Uh,
is not that we have already done, doctor. Anything else,
uh,
whatever we have not done, you want to do now?
Anything else?
Mm-hmm. Okay, doctor. So
Mm.
what is the positive physical finding, doctor?
What?
Sorry, what is the differential diagnosis, doctor?
My differential diagnosis, osteoporosis, related to the patient malabsorption disease. Based on patient have history into the hypothyroid and rated to the may be related to the celiac disease associated with history hypothyroidism and vitiligo autoimmune disease. The second differential diagnosis may be patient osteomalacia.
Mm-hmm.
The third differential diagnosis, um, patient may be osteoarthritis. Um,
So why
yes.
do you think, doctor, there is a the pain going radiating to the legs? So anything you want to um, address that part as well? There's
Uh,
a back
ال-
pain which is going towards the leg as well.
الpain is not related to the leg. Okay, I want
Pain
to
was
check sacroiliac
pain.
joint if there's any pain, if there's any
Mm-hmm.
tenderness.
Mm-hmm.
Uh-huh.
So anything you want to think of? Uh, okay, how to manage his condition? What all investigations will you send?
Okay, apart from the basic investigation, I want to do follow blood count for looking for the anemia and
Mm-hmm.
ESR, CRB for inflammatory marker, liver function test, renal function test. I want to do the
Great.
vitamin D and calcium.
Mm-hmm. Mm-hmm.
And
Okay.
also, I want to do thyroid function test and tissue
Mm-hmm.
transglutamase antibody to rule out the
Great.
celiac disease. And
Mm-hmm.
also, I want to
Great.
do the X-ray into the back and DIXA scan if indicated.
Yes. Okay. Great. Great. And how will you manage, doctor?
Regarding patient education and counseling, and
Does
patient
he
regard
does he
now,
require admission?
this patient is not needed not need to the admission. I need to
Okay.
assess patient again if there's admission or not admission.
Okay.
And also regarding to the treatment, depending on to the underlining the cause.
Okay.
Uh-huh. But if the patient is confirmed by osteoporosis, can be started
Mm-hmm.
into the patient bisphosphonate and calcium and vitamin D.
So, do you feel, do you consider that the patient might be having fracture in the back?
Yes, may have a patient fracture to the back. If the patient
Okay.
osteoporosis may be increase the risk of fracture after minor trauma
Mm.
or spontaneous.
Okay. Okay. So, suppose if it is a celiac disease, what will you do? How to manage celiac disease?
If the patient the celiac disease, the patient education about into the diet, like
Mm-hmm.
gluten-free diet.
Mm-hmm.
Yes. Uh,
Apart from that, anything else? How will you confirm the diagnosis of celiac disease?
Diagnosis of the celiac disease by tissue transglutaminase antibody
Mm-hmm.
plus IgA,
Mm-hmm.
and also anti-endomycin antibody, and
Mm-hmm.
also OGD with biopsy.
Oh, gyroscopy, right? Very good. And and how will you treat apart from the dietary restriction of the gluten? Anything else we can do?
Yes, if the patient is not improvement of the gluten, can be patient in crisis may be started steroid.
Okay. Any other medicines we can give?
Other medicine for for celiac disease.
Mm-hmm. Or okay. And what are the long-term risk factor for having a celiac disease, untreated celiac disease?
Risk factor of celiac disease.
Yes.
Yes.
No.
mm,
Long-term risks associated with the celiac disease.
yes, long
Is it
term association to the celiac disease, patient to the malabsorption, and patient increase the risk of lymphoma.
very good, very
Yes,
good.
and patient female may increase the risk of infertility.
Yes. Yes. Okay. Okay. Thank you. I think time is up, or
Yeah, yeah,
do I
six
have time?
minutes now, but it's okay. The question already informative. So you can comment now, Dr. Hassan, please.
Yes. So, yes, I think Dr. Rasa, you're Dr. Rasa, no? I feel so.
Yes, yes, yes.
Yes,
Russia.
yes, yes, Dr. Rasa. I think your histories are very good, very structured. Uh, I felt it is a little long history because you started examinations almost after 11 minutes. It might be a little long, but yeah, it was very structured. You took all past medical history, the personal history, social history, uh, mm, occupational history, allergy history. So those things were uh, very structured. Um, a few things maybe probably I would have wanted you to explore about. So you diagnosed the condition is celiac disease. How did you diagnose, Dr. Rasa? So it is a celiac disease. What made you think about a celiac disease in this condition?
Uh, by the antibody and OGD with endoscopy.
No, no. What made you think on in the basis of the history that it is a celiac disease?
Yes, in the history, the patient presented with diarrhea and
Hmm.
abdominal pain, loose motion, and abdominal pain, and also the
Hmm.
patient association to the other autoimmune disease.
Yes, very good. So we have given two autoimmune diseases. Have given a history to think about some other autoimmune associations and the history of loose motion going out with an uncontrolled food that might be very significant. And I told volunteer to tell that whenever she takes beer, which are mostly made of wheats, she develops stomach upset. So most of the time, anybody with a celiac disease, they cannot tolerate beer, and we need to have a safety netting not to have beer as a alcoholic beverages. That is number one. Second thing is that one thing probably physical examination part, I would probably you didn't get any time to do it, but somebody who is telling that back pain radiating to the legs, we should have we can expect to do some neurological tests on the lower limb, like at least in form of planters, taking some motor examination, checking the reflexes and the sensations, because the the pain which radiates to the legs, it tells maybe he might be developing some neurogenic claudications due to osteoporotic fracture, which might be compressing the nerve roots and the nerve roots of the spinal cord. So that might have been done in the physical examination. That is number one. Second thing is that we could have offered for the straight leg raise test in all patients with the back pain to understand. We usually, I think we usually do not do it, but we just offer it the straight leg raising test. And uh, and and for the spinal movements, whether the spinal movements, it's a lumbar pain, whether it's a mechanical kind of back pain, whether any restriction in the movement of the spine in the spine there or not. That is number one. So it is basically a mechanical back pain. It's not inflammatory back pain because there is no morning stiffness that you have inquired and excluded. Uh, coming to rest, everything I think you have done. You've checked for the pallor, which might not be there, thyroid, and you could have checked whether any thyroid swelling there or not because there is a history of thyroid hypothyroidism. Just offered some water and then ask her to take a swallow to see that whether there is any thyroid swelling there or not. And the vitiligo patches, I've already told the vitiligo patches. You could have asked the where is the vitiligo patch and see that the to demonstrate I have seen the physical examination, or you could have told in the physical examination finding that I have noticed a vitiligo over there. So this is my thing. Rest differential diagnosis was good. Celiac disease causing osteoporosis. Uh, but first differential diagnosis would be osteoporotic fracture over here because it's a persistent back pain and which is increasing and then now pain radiating to the legs. So maybe it is an osteoporotic fracture causing some feature, compressive symptoms. Uh, and osteoporosis is might be due to celiac disease. In celiac disease, so it's a kind of sometimes most of the time it is a malabsorption kind of things. Sometimes it might be non-malabsorption also if it is non-long acting. So any kind of malabsorptive diarrhea, we try to explore whether there is any evidence of like
Vitamin D deficiency causes osteoporosis. We could have asked for the vitamin A deficiency signs, vitamin E deficiency signs like hair loss or something. Vitamin K deficiency causing easy bruisability or ecchymotic patches. So those things we may have asked. Rest everything is fine. Clinical judgment is very good. Differential diagnosis is good. Rest things. I think everything. Doctor, you have done very nicely.
Okay. Thank you, Dr. Sen. Let's start again from the skills, starting by physical examination. What do you think about the judgment? Did she do the steps of physical examination?
In the physical examination steps, only thing examination of the back and
Yeah.
neurological examination of the lower limb. I think
So,
should have done.
yeah. So I think maybe it will be either borderline or unsatisfactory. Why? Because this is the main complaint. She didn't roll out or she didn't do the examination of the lower limb, which is important here to roll out any neurological manifestation, right?
Yeah, I would. Yeah.
So for me, I don't think she can get good mark in the physical examination. I think also because of the time management. So let's
Yeah.
give her uh, unsatisfactory. For me, I will give unsatisfactory for the physical examination. What about identify the finding?
So it becomes a kind of more linked marking, but she has identified there is no physical findings would have been there. So because
Yeah, but
there will not be any weakness, there will not be any reflex changes, hyperreflexia. So she has identified all the physical signs that were
okay.
present.
So maybe as borderline.
Yes,
The
yes,
clinical communication, I agree, and I believe she deserved the full mark, satisfactory, because she asked
yes.
everything. Maybe this is the reason also she didn't have the time to examine. Okay.
Yes, yes.
So it's okay to ask, but at the same time, try to have good time for the examination. So whenever you have finding, you can analyze it, but don't take long. Unfortunately, you analyze the diarrhea more long time, and of course, it take from the examination time. The diarrhea, once the patient is trying to be, uh, let's say, Dr. Hussein wasn't clear about his diarrhea. He's saying that diarrhea is coming and going on and off. I noticed related. You ask about pizza and pasta, and he wasn't clear about his answer. So you can ask another question. Do you think the diarrhea or the loose motion was flushable? You want to know this is celiac or no, right? And you have high suspicious this is a celiac disease
Mm.
and loose motion related. So you can ask other questions related to celiac apart from the relation to the food. So you can ask about, as I said, and you, Doctor, I think Dr. Rasha asked lastly about the flesh, the bulk. Is it bulky?
Yes, yes.
Yeah. So the main question can roll out the loose motion or the celiac diarrhea or malabsorbed diarrhea is flashability. Is it flashable or no? And the answer will be clear. No, it is not flashable. Then you can close this chapter. No need to ask more about this. Let's go to the next system or the next skill, the clinical judgment. I think also she covered most of the things. She recognized the case. She analyzed the autoimmune association, the relation, the link between all these symptoms. So she can get also good marks, satisfactory in the clinical judgment. Then the differential. I prefer to say it's mechanical back pain, Dr. Rasha. So the examiner will know that even if you give another differential, you are understanding what you give. Okay, you are giving differential of mechanical back pain. Whatever you mention this term, he will know that whatever the differential you give, hopefully it will be correct. Okay, so you give three of them, which is correct, but you have to mention fracture. So the osteoporosis itself, it doesn't cause pain, right? Whenever the fracture happen on the osteoporotic bone, now we can say this is it will lead to back pain. Otherwise, you will not have, or the patient will not have back pain. So you have to say, and you said it at the end, that the patient had minor trauma lead to the fracture. Um, the examiner might minus you in the clinical judgment that you didn't call the neurosurgery, and you said no admission, right? Or I will assist the patient. It's good to say good. I will assist the patient, but why you are not referring to the neurosurgeon? This patient is having neurological manifestation, so I should be safe to call multidisciplinarity. By the way, admission decision in PACES is the tricky point. Don't judge and say I will not admit the patient by yourself. It's tricky answer. It might also uh, have a risk to minus you in this in the clinical judgment skill. Whenever the examiner asking, will you admit the patient? Think million times before answering this, because admitting the patient or discharging the patient unnecessarily or after, if you didn't call multidisciplinary team approach, you are unsafe doctor. So the best way, never discharge. I will call other departments or other teams to assist the patient with me. I am not alone there. By this way, the examiner will know that you are safe, doctor. So don't rush to say, I will not admit the patient. Think million times before saying this word. So what I should say, I will say, I will refer the patient to group of doctor, right? Sorry, anyone want to talk? Someone was talking. Okay, let's assume the skills. So again, for the clinical judgment, yes, I might minus you in the clinical judgment. Sorry, I said earlier for satisfactory, but for me, after saying I will not accept the patient or I will not admit the patient, you are unsafe, so it might down the mark in the clinical judgment. The differential diagnosis again, so as you mentioned, mechanical back pain, you give three of them, the fracture or the osteoporotic fracture, the osteomalacia, also one of the back pain, mechanical back pain, and osteomyelitis. Okay, you can mention it. You can also mention trauma itself, even without the osteoporosis or disc prolapse. All of them are causes of mechanical back pain. If there is suspicious of infection, you can say also discitis is one of the causes, or osteolytic lesion if you have suspicious of cancer. These are the most common cause of mechanical back pain. Spinal stenosis, I think also Dr. Sen mentioned it, but it's not the case. Then the concern maintained, the welfare also maintained, so satisfactory and all. So I think these are the judgment. Do you agree, Dr. Sen?
You are a very tough examiner, sir.
Yeah,
I will not be very tough.
no,
Uh,
no. Let's assume most of the examiners are tough. Okay, you don't know what center you are belong.
so, sir.
Uh, yes, so you cannot assume the all examiner will be kind. You don't know that. And
No.
to be honest, it's not a rule. By default, the examiner are not tough, are not kind. Some of them are kind, but by default, they are not. So be ready to have good answers, to be more confident, to say good and correct judgment regarding the admission, the investigation. However, Dr. Rasha did perfect, but the physical examination and the identify the finding will depend on the time. Whenever you are done with your history, try to examine the patient. Don't wait further, because if you take lengthy to examine, sorry, to take history, you have a risk not to examine the patient and you will miss two skills. Okay, two skills might be affected by this the physical examination and the identify the finding. On the other hand, if you examine the patient and you didn't answer the consent, 2 minutes left, you didn't go to the consent, it will be one skill impaired, but better than two skills. Okay, you get it, Dr. Rasha?
But regarding the differential diagnosis,
Yeah.
osteoporosis and osteomalacia, and the third,
Third, disc prolapse or trauma lead to fracture again without osteoporosis. But is disc prolapse also can cause it? It's one
can
of the
I put
factors there.
osteoarthritis?
Okay, osteoarthritis, but usually osteoarthritis
Mechanical
happens.
pain.
Yeah, it can cause, but it comes with the mobile joint. Not it's not common to be in the back. Usually in the mobile joint, right?
The, and the age is a little younger for the osteoarthritis. So I agree it will be kind of this prolapse would be a
Yeah,
better.
yeah.
Uh,
Prolapse
Mm-hmm.
it can be the fitting to the differential. Okay.
Yes.
Any other question?
Yes, Dr. Basim.
Yes,
Uh,
Dr. Mahmoud.
Actually, what I like in Dr. Rasha, she's so confident and fluent in the asking the questions. But I think if we look, she took a very long time in history. At the end, if she took long time, although she got the diagnosis early, yani the clue about the celiac early, and she put in her mind the osteoporosis also early. But At the end, if you took 10 minutes or 11 minutes or 6 minutes, at the end, the clinical communication, the full mark is only 4. While the steps of the examination and the clinical finding, it equal 8. 4 plus 4, 8. And this clinical finding will depend, there is a lot of things, it will be depend upon them. And for example, the differential diagnosis, it will be depend on the finding. The clinical judgment, it will depend on the finding. The differential diagnosis, it will depend on the finding. So I prefer if you took less time. And also I will add in the celiac disease, you can add also only one sentence question to confirm. Is it regarding the loose motion? Is it pale, bulky, smelly, and difficult to flush? This will close that one. And also the Dr. Basim is also mentioned regarding the diagnosis. It is osteoporotic fracture number 1, because as Dr. Basim said, osteoporosis by itself, it will not cause pain. It's painless osteoporosis. But with the history of fall, you can put the first differential diagnosis is to osteoporotic fracture, and then you can put the other. But overall, you did great.
Yeah, thank you, Dr. Mahjoub. Nice comment. How to fix this problem whenever you are taking long time with the history? What you can do to overcome this problem? Okay, I have, for example, I reached to the minute 12 and I didn't do any examination steps, or even I hear 2 minutes left and I didn't do any examination. What should I do to at least have the full half mark of the skill of examination? At least to examine the affected part in the complaint. Okay, at least you should examine that I would like to examine his back. Then from the back, I would like to examine the neurological examination of the lower limb. By this way, so I can get at least the half mark. I will not get the full mark, of course. And then I can say I would like to do so 1, 2, 3 if I have time, but I don't have time. Then I will ask the concern while examining the patient. So by this way, I reserve my time, the last 2 minutes, for both skills or 3 skills: physical examination, identify the finding, and concern. Of course, it depends on your experience and, of course, control on your stress. Because by this way, you'll be panic. Whenever you hear 2 minutes left and you didn't do examination, you'll be panic. What should I do? I cannot do anything. Then I will be mentally blocked. So it depends on your control, on your stress. If you are doing so, you can gain the 3 marks of the 3 skills, the full marks of the 3 skills. Examining quickly the back, show me the legs, the power, tone, reflexes. What's your concern while doing the examination? However, it's difficult, but at least to maintain some of the marks from all skills. Better than unsatisfactory, because whenever you overlook the concern, they might give you unsatisfactory, of course, and the if examination as well. If you didn't do the examination, they will minus you or unsatisfied even mark for the physical examination if you didn't start the examination. Again, the most important to examine the main complaint. What I have back pain, I will go to the back pain. Examination of the back and lower limb. If I have time, I will ask for the vitals, then the thyroid, one of the positive finding, the pallor. Okay. In this way, you can gain some marks. Thank you again, Dr. Mahjoub. Anyone
Some
wants
of
some?
them, I will
Yes.
add just only one
Yeah.
sentence. Some of them, they will solve this problem, Dr. Basim.
Yeah.
They will do the history of present illness. They will check for causes or complication. Then they will let the PDFs at the final. Then directly they will examine the patient. Yani after they will do like this, the history of presenting illness, maybe like Dr. Rasha, she cuts the diagnosis. She will let the rest of the history until
Yeah.
she
After
will
the
do
examination.
examination and finding. Then she
Yes.
will
Exactly.
come out, she will select which is important. And for
Exactly.
example, if the driving is important issue, she will talk about the driving, the medication, the past medical history, and at the end she will not get unsatisfactory because she got diagnosis in the clinical communication. While in
Exactly.
the other, she will got all the findings and she will do like that.
Yeah. So again, it depends on your experience taking history, managing your time and the history as well. And this happen whenever you are doing the practice in the sessions. It's not the exam because the exam is different situation. Believe me, the time will be more faster than the session itself. Okay, and you cannot look at the watch. You cannot feel the time itself. It will just pass. So what I have to do, my question should be to the point. I will not take lengthy to analyze a complaint like here in the area. I will try to give or ask three questions quickly. I will not give time to the surrogate to play with me the game. If I leave the leadership to the surrogate to talk, he will not finish. He will say, Doctor, I'm traveling to my cousin, I eat some food, then he give it happened. So he's the one wasting your time and you are the one allowing this. So what I should do, I should give him target question to know what if he has the celiac or no. The target question, as Dr. Mahjoub said, and I said earlier, relation to the food. If you feel that he's playing with the word, doctor, sometimes I feel it related, sometimes no. Okay, forget about this question. Of course, after saying pizza, pasta, beer, this substance that it can cause the diarrhea. If not clear, you can go to the flashability. Is it flashable? How the smell? Is it offensive? And is it large amount? Okay. These three questions can give you the clue this is a celiac disease. By the way, you have two evidence this patient is having celiac, the thyroid itself and the vitiligo. Patient already mentioned and volunteered to say to you, I have vitiligo, doctor. So 80% this is a manifestation of celiac, or this loose motion is celiac. Okay. Thank you, Dr. Mahjoub. Any other question or comment from others? Okay, I will read the comment. Dr. Rasha, please, can you post your scenario for Dr. Hussein? Earlier comment about patient already has boyfriend. This is no need to ask. Okay, when to ask about the casual relationships? Whenever you suspect HIV or sexual transmitted disease, you can ask this question. But not every patient, I will ask him if you have casual relationships. They don't like this behavior to ask every patient with this as a routine question. I am suspecting HIV, I can ask this question. I'm suspecting sexually transmitted disease, skin rash, I can ask this question. Otherwise, it's enough to ask about three P's, period and pills, control pills, and pregnancy. Are you pregnant by any chance? That's it. I'm suspecting infectious disease. That time I can ask about, you have a partner? Yes, doctor. Do you have any other casual relationships? Is it protected in this way? If I have highly suspicious of TB or sorry, of infectious disease like HIV. Otherwise, not as a routine question to ask this one. The next summary of positive finding, yes, I mentioned already, back pain after fall down, minor trauma, history of hypothyroidism on and hyper and thyroxine replacement, vitiligo was there also, loose motion on and off. He mentioned the beer worsen his GI symptoms. Celiac, yes, of course. It's the case, celiac disease, as a part of autoimmune manifestation. Dr. Ahad, I think also in the context of trauma and neuro manifestation, we can also add disc herniation. Perfect. This is what we mentioned here, disc herniation or disc prolapse. What do you think, Doctor? Yes, I mentioned it. So, disc herniation or disc prolapse, one of the differential after a trauma or fall down. Dr. Ralim, targeted question, yes, or say I will complete my examination by doing, etc. Perfect. It's good also and a smart way to fulfill this skill. It will show the examiner that the history was lengthy, so that's why I couldn't do the all examination steps. And if I have the time, I can do 1, 2, 3. Dr. Sen, your scenario. Sarah, 35 years old, presented with chest pain.
Just give me
Prepare.
a few
Yeah,
minutes.
sure. Yeah, we'll open the discussion. Anyone want to add any comments? Please feel free. Okay, thank you, Dr. Inas. I hope Dr. Sen will not look at the chat box, so don't try to look at the chat box. It was a habit to open the differential or to open the chat for the differential diagnosis for our case. So I hope you will not look at the chat box, Dr. Hussein, okay? Anyone want to write the differential initially before starting the case? Feel free to write it in the chat box.
Should I start or you want to wait, sir?
Okay, here you go.
Should I start?
Yes, you can
Yes.
start. Yes, here you go. I will set the
Oh,
timer
okay.
again. You can start.
Okay. Okay. Yeah. Hello, I am Dr. Sain. I am doctor in the clinic today. Am I speaking to Miss Sarah? And you are 35-year-old.
Yes, I am.
Miss Sarah, I have seen from the note that you have come with some chest pain. Today, I am here to talk to more about your problem, and I will do some necessary examinations. Is that okay?
Yes, doctor.
Okay. So, can you please tell me more about chest pain, Miss Sarah?
Yes, doctor. I had chest pain since into the 2 days back. It was started to sudden and getting worse.
Okay. I'm so sorry to hear your problem. Where exactly you're having this chest pain?
In center to the my chest.
Okay. Is it happening for the first time or it happened in the past as well?
Is it the first time?
What do you think that increases your pain or anything that relieves your pain?
Like what, doctor? I think
So
there's no
any kind of,
anything release the pain. There's no anything improve the pain.
do you take any painkillers for it?
Uh, yes, doctor, but there's not improvement.
Okay, so how severe if I tell you to rate the pain from 0 to 1, how severe it would be?
How what?
How severe the pain would be if I tell you to rate from 0 to 1?
Yes, between 5 and 6.
Okay, okay. Does the pain go anywhere from the central part of your chest?
No,
What kind of pain it is? Is a kind of dull pain, crushing pain, stabbing pain? Can you please
like dull aching, doctor, like tightness.
tighten? Oh, okay,
Mm-hmm.
okay, sorry. Does it go to your jaw or to your abdomen
No,
or to your tummy? Sorry.
no.
Okay. Okay. Apart from this chest pain, do you have any shortness of breath?
Yes, doctor.
Uh, okay. So when do you feel shortness of breath? So with uh, some exertion or some walking or doing something.
In the exertion and in the last 2 hour, even in the rest, doctor. I can't breathe properly, doctor. I feel
Oh, I'm
pain when I talk breathing.
oh, I'm so sorry that you're feeling breathless
Mm-hmm.
even at rest. So at this moment, any cough
Mm-hmm.
you have,
No,
any blood sputum you have.
no.
Apart from that, may I know that any long-term medical illness you are suffering from?
I don't have any medical illness.
Any any medicines you take round the clock?
No, no,
Any
doctor.
previous any previous hospitalization?
No,
Any previous procedure?
no,
Any previous surgery?
no,
Any blood transfusion in the past?
no,
Any over-the-counter medicines?
no.
May I ask you if uh, anybody in the family is having significant medical problem,
Like what, doctor?
like suffering from any cancer or any other heart problem or lung problem or clot problem,
No,
stroke?
no,
Are you allergic to any medicines?
no.
May I ask you a few personal questions if you may allow?
Yes, doctor.
Do you smoke?
No,
Have you ever smoked?
no,
Do you drink alcohol?
no.
What do you do for living?
I'm a teacher.
How do you feel these things are affecting your life and your job?
Yes, doctor. Just only 2 days, doctor.
Okay, I'll try to get the bottom of this problem.
Mm-hmm.
Do you drive?
No.
Okay, I may ask you a few more personal questions if you may allow.
Yes, doctor.
Um, do you have regular periods, Mrs.
Yes,
Sarah? When
yes.
is the last time you had your periods?
When what?
When is the last time you had periods?
In the last 3 week.
Okay.
Mm.
Uh, and your periods are regular.
Yes.
Do you have any partner?
No.
Sorry to ask, do you have any child loss anytime or pregnancy loss anytime?
No.
Okay. Did you travel anywhere recently?
No.
Uh, and uh, okay. And apart from that, I'll just ask you a few more questions. Do you have any tummy pain?
No.
Do you have any loose stool?
No.
Do you have any changes in the eyes?
Changes. No.
Any vision problem? Any redness in your eyes?
Yes, doctor. I have heart racing problem. Yes.
You have a heart racing.
Yes.
Okay. Any sort, when do you feel the heart racing?
The same period, doctor, since 2 days.
Okay. So how, can you please tap on the table that the whether it is regular, irregular, or can you please tap on the table?
I am not sure, doctor, is regular or irregular, but I feel is very rapid.
Oh, okay. I'm so sorry to hear that. Is this happening for the first time or this has happened in the past as well?
Is it the first time?
Uh, Apart from that, did you have any headache,
No.
any abnormal sweating?
No.
Do you have any weather preference?
No.
Uh, and do you notice uh, any change in your bowel habits?
No.
Any change in your water works?
Like what, doctor? Change into the water work?
Like, did you notice any change in color of your water works?
Yes, doctor. Recently, there is one time I noted a change into the my water work.
Mm-hmm. So it's turned dark or black or something like that.
It's become more red, doctor.
It became more red.
Mm-hmm.
Okay, okay. Uh, uh, okay, so is the redness was that at the beginning only, or it after some time it turned?
After what?
It, was the redness from the beginning only?
I don't know though. Yes, doctor. In the beginning.
Okay, okay. Did you have any pain?
No. What you mean, doctor? By in the beginning?
Uh, Beginning of your waterworks, or it is in the end of the waterworks?
Uh, I am not sure, doctor. But I think all the water work is become more red.
Okay, any pain at the time of passing waterworks?
No.
Any burning sensation?
No.
Okay, okay. And apart from that, do you have any rash anywhere in the body?
Rash? No.
Any soreness in the mouth or in the private parts?
No.
Okay. Do you feel any lumpness any part of your in your tummy?
No.
Okay. Any cough?
No.
Okay. May I examine it?
Yes. What you want to examine?
Okay. I'll just first of all see for the general physical survey. So look for any pallor because he's having redness.
There's no
So
pallor.
and I'll just ask that anywhere else you have any kind of bleeding from any place from your body?
There's no bleeding.
Okay. Okay. What about your mood?
The mood is good.
Great. Great. Okay, so I'll look for the pallor. Is there any icterus? Whether any I look check for the blood pressure. Whether any postural drop in the blood pressure there or not.
There's no posture drop into the blood pressure.
Okay, look in the oral cavity of for any oral ulcers.
There's no ulcer.
Okay, and then uh, I will do the cardiovascular examination because she has any palpitations. So the pulse is rate, rhythm, and volume of the pulse.
The
Any
pulse is
irregularity of the
tachycardia.
pulse? Huh?
The pulse is tachycardia and regular.
Tachycardia and the regular. Okay.
Mm-hmm.
Auscultation sub, I'll check for the apex pitch, auscultate the heart for the heart sounds and the any murmurs.
Mm-hmm. الإبط beat in place. There's no any murmur.
Okay, and the blood, how much is the blood pressure you have told, doctor?
Blood pressure 120 over 90.
Okay, and there is no postural drop.
Mm-hmm.
Then I'll go to the legs, whether any leg swelling is there or not.
There's no leg swelling.
Okay, and the any pulses in the legs are well felt.
Pulses?
Pulse, the dorsal
No.
pedis.
No. No need. No need.
Right. Okay, then I'll go to the abdominal examination, do some superficial palpations, and the deep
Uh,
palpations for any organomegaly. Look for the
uh,
bilateral kidney.
Superficial palpation, there's no any mass, there's no any tenderness. Abdominal examination, there's no any organomegaly.
Okay. And do you have any weakness in any parts of your body?
No.
Okay, okay, okay. Uh, okay. And uh, anytime you had any history of any clot?
Any history of a clot?
Mm-hmm.
No.
Any history of any? Do you have any history of any? Uh, any past history of any? Uh, okay, what is your concern, Mrs. Rasa? Mrs. Sarah.
Doctor, I want to know what I have.
Hmm, hmm, Yeah, okay. So mm, your concerns are understandable. You have a chest pain for the last few days. And just before that, did you have any kind of recent raised body temperature?
No.
Okay, okay, okay. And no joint pain, nothing. You
Joint
don't have
pain?
any
No
joint.
joint pain. No joint pain.
Okay, so for the timing, your heart rate is high after examining you and after talking to you. What I can find, that your heart rate is quite high, and your chest pain might be related to your related to your some amount of cardiac conditions,
Mm-hmm.
heart related condition. So what we need to do at this point of time, we need to essentially admit you and do some necessary tests, like we do some electrical tracing of the heart, and we do some. You have some breathing problem as well, so we might need to do some scan, do some blood test uh, before coming to a conclusion to the what exact problem. But it is important to get to the bottom of the problem.
2 minutes left.
Mm-hmm.
Any other problem you have? Any
Yes,
other
doctor,
concern?
you want to admit me, doctor. What is the heart problem, doctor, I had?
It is important to we'll run some basic tests, and after that probably we'll come back with my senior and the consultant to tell you the exact problem. At this moment, I do
Mm-hmm.
not have any specific diagnosis to tell you, but what it means that you are breathless even at rest. You have pain, uh, which is bothersome, and your heart rate is quite high. So it is important to get to the uh, bottom of this problem.
Mm-hmm. Is it serious, doctor?
Mm, uh, I'll have to come back after this and in some tests to tell you. Most of the time, the things are treatable, and
Mm-hmm.
the certain things probably might need to do some adjustment to your life, and after that, we can take a call. Will that be okay
Mm-hmm.
that if we run some basic tests and then come back to the answers for that?
Mm-hmm.
Any other concern you have?
No, doctor.
Okay, okay. Thank you, Doctor, for seeing.
Okay, any question you want to ask? You have 20 seconds. The good thing
Uh,
you have time. And the opposite of Dr.
Uh,
Sarah scenario.
okay. Wait one me.
Okay, 10 seconds. Or
Doctor, is my problem to the water work related to the my condition?
uh, yes, it might be related to what related to the waterworks in your condition.
Mm-hmm.
So we'll run some tests for your waterworks as well.
okay, time's up now. Questions for examiner. Dr.
Okay, presenting a
Shaikh.
case.
So I've taken a history from a 35-year-old lady who came with a chest pain for the last 2 days and the gradually increasing shortness of breath. She is tachycardic, and apart from that, in the physical findings, there is no other physical finding which is significant. On one on the history,
Did you check?
the
Did you auscultation the chest?
uh, oscar to the chest. Oh, I didn't oscar the chest. Okay.
Okay.
No.
Did you ask about the oxygen saturation?
No, I should have offered for the oxygen saturation.
Mm-hmm. Okay. Okay. Regarding to the finding, what is what's your differential diagnosis?
First thing that I'd like to rule out in this age that is the pulmonary embolism in the young female. She has a history of change in color of the urine, so it can be PNH. Uh, so it can be a pulmonary embolism related to the paroxysmal nocturnal hemoglobinuria. Apart from that, also I would like to rule out any uh, other causes of acute chest pain like pleurisy, pericarditis. Although there is no history of any recent fever, uh, and and if the female is tall, then I would like to see for any spontaneous pneumothorax also.
Mm-hmm. What are the risks of spontaneous pneumothorax in this patient?
Sorry.
What are the risks of a patient spontaneous pneumothorax in this patient?
If the patient is tall, then she can develop
Did
spontaneous
you measure
pneumothorax.
did you the measure span of the patient to tell the patient tall or not?
No, so I need to see the patient. I cannot see the patient.
Mm-hmm. Did you check auscultation the chest for pneumothorax?
Now, I should have ausculted the chest for the pneumothorax. I missed that.
Okay. Okay. How to investigate?
Apart from the basic investigation, I would like to first of all do the specific test to understand diagnose the cause of the chest pain. I would do the ECG, X-ray,
Mm-hmm.
chest X-ray, the
Mm-hmm.
ABG for her. I'll check for the oxygen level in the for her. I'll do the 2D echocardiography. I'll check for the D dimer, check for the cardiac enzymes, troponin, and proBNP. And if the chest X-ray, sometimes very small pneumothorax might not get picked up, so I might need to do a HSCT of chest.
Mm-hmm.
So this will be my initial set of investigations.
Okay. If the patient have history of itchy, what are your differential diagnosis?
History of, sorry,
Itchy.
itchy means,
If the patient have history of the itchy, special after hot bath.
sorry, can you please come again?
If patient has history of itchy, special after the hot bath, what are your differential diagnosis?
Oh, what is itchy?
Itchy. You mean itchy?
Itchiness.
Itching,
Itchiness.
itching.
Itch, yes.
Okay, okay. Patient of itching after
Uh-huh.
hot bath.
Mm-hmm.
Okay, okay. So, if somebody is having itching after hot bath, then I would think of polycythemia.
Mm-hmm. Okay.
So, but I asked her whether she has any headache and all. Those things were not there. So I excluded, kept that thing aside from my diagnosis.
But yes, ask about the headache, but not ask about any itchiness.
Okay, yeah, okay.
Okay. Okay. How to treat?
Treatment will be based on the diagnosis, first of all.
Mm-hmm.
I
Okay.
do not know at this moment what is the diagnosis. So if it is a pneumothorax, the diagnosis, then the treatment will be as per the, she might require single needle aspiration or she might require intercostal drainage depending on the size of the pneumothorax. If there is an evidence of CTPA shows evidence of pulmonary embolism, which is causing
Mm-hmm.
breathlessness and tachycardia, then she will require immediate admission and the blood thinners for that.
Mm-hmm. If the patient being itch, how to diagnosis?
Patient is, sorry,
Being itch, paroxysmal nocturnal hemoglobinuria, how to diagnosis?
for pediatric, for PNH, we need to do a flow cytometry
Mm-hmm.
to diagnose the PNH.
Cytometry, flow cytometry for which?
For CD 50, 55 and 52.
Okay. How
Lens.
to treat?
Treatment for that is chemotherapy.
Which is the cold?
I I forgot.
Okay. I think time up.
Yes, time is up. You can comment now
Mhm.
based on the skills.
Yes, regarding to the clinical history, you did well. But if patient tell you I have history of hematuria, that only to the one time, you didn't ask if there's any morning hematuria.
Hmm.
Mhm. Okay. Um, you didn't ask if
Is it
there
hematuria or dark urine in standing?
change
Yeah,
the
that is
color of the
actually
urine.
specifically.
Yes,
Yeah.
they didn't ask the patient if there's any morning.
Yeah.
Uh-huh.
So
Okay,
Usually in
supposed to be
teenage, what
more.
happens? Usually in the teenage, what happens is the urine
You
color
have to ask Dr. Sen. Don't
changes.
wait for her to clarify. You have to ask.
Yes, because the
Yeah.
surrogate is not clarified without asking.
Yes, you have to ask
Mhm.
specific question. Okay,
Hmm.
continue, Dr. Asha. Sorry.
Yes, the second patient, female, younger age group, you didn't ask about the systemic lupus, skin rash to the sun exposed area.
Actually, I asked for the joint pain and the oral
Ask
ulcers
about the joint pain, just only about into the joint pain. Mm-hmm.
and the oral
And
ulcers I've asked.
regarding to the Bahja disease is asked. You didn't ask about the itchy because to rule out polycythemia rubra is
Hmm.
important. Ask about the family history of a clot and briefest history of a clot. Ask me about the sweat and weather preference, but I think there's no benefit from these the questions. And also in examination, you didn't ask about the oxygen pulse oximetry because it's important. Okay,
Hmm.
you didn't find to the patient of any pulmonary erythema if there is for pulmonary erythema for polycythemia rubra. You didn't examine to the chest. Okay, is it important? Is important the chest because you tell the your differential diagnosis as pneumothorax. Yes, you can tell pneumothorax without examination to the chest because can ask the examiner based on what the patient pneumothorax. Okay. Um, Yes, they didn't ask if there's any history of a bleeding because the treatment you need to start into the anticoagulant. You need to ask the patient if there's any history into the bleeding or not.
I asked that there is any bleeding of anywhere
Ask
else in
bleeding.
the body.
Okay. Just only this.
I asked bleeding anywhere in the apart from this. Anywhere else also I've asked whether any bleeding in the cough, bleeding in the uh, motion, those things I've asked. Yeah.
Okay. Mm-hmm.
Okay, so let's judge again on the skills one by one. The physical examination, do you think he satisfied the examiner?
Yes, the physical examination. Okay.
No, I don't think it's okay. He didn't examine the chest, which is
Yeah.
the
The
most.
physical sign. The physical sign examination to the chest. Yes.
Yes, so a physical examination means to examine the system could be affected or could be having finding. Here, the most important system, which is the relevant system, the chest and cardiovascular. And I
Yes.
don't think he did full examination of both of them,
Yes, but I
right?
think the chest a physical sign. Yes.
Yeah, physical sign.
Mm. Oh,
Still, we
okay.
didn't talk about picking up the finding. So there is
Mm-hmm.
difference between physical examination. I have to do the steps. Picking up the finding or identifying the findings. If I find, for example, the decrease air entry, there is crackles, I should mention it. So
Yeah.
the second skill will depend on the first skill. If he do the steps, he will pick up the finding. If he didn't do the steps, he will not pick up the finding. So for me, both skills will be minus, down maybe borderline, or as maybe lower to unsatisfactory because he didn't examine the affected the same as you did, Dr. Rasha. So he didn't examine the complaints or the system related to the complaint. I have chest pain. What I
Examine the
should
back. Examine the back.
the listen.
Eh,
Whenever you have chest problem, you have to do full chest examination, not only the back. Chest
No, no,
examination means
regarding my case, not regarding this
okay,
case. Mm.
okay.
But I
You
think
examine the back.
regarding this,
Okay,
the chest examination in this case, examine auscultation and chest
not only
expansion.
auscultation,
Not,
everything: inspection, palpation, percussion, auscultation. It's a matter
but
of exam show. It's not just examine without steps. So it's examination steps means I have to do the full examination steps: inspection, palpation, percussion, auscultation. Why? Because I have complaint, clear complaint about chest pain. So I have to do the chest examination in the four full steps: inspection, palpation, auscultation, percussion, auscultation. Okay? Because what else I can examine here? We will talk about it. Okay? But in the most important system to be examined fully, it will be the chest and
yes,
cardiovascular.
cardiorespiratory. Mhm.
Okay, so we can give him either borderline in both skills or unsatisfactory in physical examination. Anyway, let's talk about the communication, clinical communication skill. What do you think? Did he satisfy you?
Yes, yes,
Okay, for me, he didn't fulfill the all finding or the all history related to the finding, which is pulmonary embolism on the top of my differential. He didn't analyze for PNH, although he asked. And also, he didn't ask about travel history. I wrote
yes.
it. He asked?
Ask
Oh,
about
okay,
travel
sorry.
history. Yes,
Okay, I'm
ask.
so sorry. Okay, I wrote it, but so he asked. Okay, miscarriage. Did he ask about miscarriage? He asked about female history, but I didn't hear
Yeah, I
about
asked
miscarriage.
about the pregnancy loss, although he
Yes,
didn't
Really?
ask.
answer.
Yes,
But
ask about
Okay.
the pregnancy loss. Ask
So
about
every
the systemic
question,
lupus. Yes, ask about the
perfect.
Bahjat disease.
Okay,
Ask about the family history of a clot and previous history of a clot.
perfect. Okay,
Mhm.
so I can give in the communication, but the history was little bit disorganized. Even the last question in the systemic review, you ask about any cough, and you ask earlier about cough. Why you are repeating the question, Dr. Sen? Because you are not
uh, yeah,
organized.
that's
You are not
Yes,
organized.
and ask. Yes, and also ask about the palpitation in the last thing.
Yeah, and he
Mm-hmm.
asked also about, he repeated question, another question, I think about fever or something like that. So why I'm repeating the question, whenever I am asking as randomly questioning, as Dr. Sid did, you are asking like from everywhere. I'm asking about the constitutional. So I will ask one question about constitutional, then I will go to the systemic review. I will ask about sputum and phlegm. Then I will ask about lower limb. I will ask about headache, vision. You have to be systematic and organized. Why? Because you will look like this in the front of the examiner. Not only that, you will miss questions or you will repeat questions. When I will not repeat, whenever I am doing it in organized way. For example, if you start the systemic view from the head down to the toe, which is my favorite approach, after, of course, constitutional symptoms and past medical history and the relevant system and complaint. The systemic review, if I start to ask about CNS, then the endocrine, then the chest, and the cardiovascular, abdomen, your genitourinary, musculoskeletal, never ever you will repeat a question. Why? Because I finish every system grossly, so I will not go back to this system again because I finished already. Okay, and then for the clinical question, he can get borderline because of this disorganized way. For the clinical judgment, I agree he managed the case well. But please, whenever you have chest pain and there is possibility of pulmonary embolism, ask about hypoxia or the saturation. And if there is hypoxia, you can even offer oxygen. Not only that, whenever you have chest pain or any pain, if you ask about the scale and the pain more than 5, you have to offer painkiller. Okay? Just offer. Please, can you give this lady paracetamol, please? It's an act. We know and we believe this is an act. So I will order for paracetamol or any painkiller if the scale more than 5. This is regarding the clinical judgment. The admission, Yes, patient need to be admitted. The investigation, you have to investigate for every hypercoagulable state. BCR, sorry, polycythemia rubra vera, yes. And the BEHSIT mentioned already, the family history, the travel, measuring the calf muscle. Is it appropriate to offer, Dr. Sen, in the examination, and you can do it in the
Yes,
investigation?
yes, it
Yeah,
should.
in particular, if there is family, if there is travel history, you have to do. Okay. If there is history of leg swelling, I have to measure the circumference of the leg or the calf, and to do examination as well. So the differential, what you mentioned, three. Give me the three differential you picked up from this scenario.
So I told about pulmonary embolism,
Perfect.
then spontaneous pneumothorax.
Okay. Whenever you give differential, you have to have evidence. Why I will say spontaneous pneumothorax? Is it Marfan patient? Is it COPD patient? Right? Or is it something collagen disease? It's not the matter to give any differential. No, I have to give sensible differential. By the way, they are judging on your differential, not for the account, for the most relevant and sensible one. So I can give
Yes, and
another
also I
differential.
think the examiner asked you, did you auscultation the chest for to
Exactly.
say thorax?
Okay, give me another differential. Yes, pneumothorax always can be there as a differential, but does it make sense to say differential pneumothorax in, for example, short patient, no suspicious of Marfan finding? It's not that common one. So let's go, or if the patient is smoking, you can say it. Okay, let's go to other differential. What else you wrote and you can give in this scenario in particular? Pulmonary embolism, then?
Uh, had there been a history of some fever, then I would have told that they thought of some pleurisy or
Okay, so
pericarditis.
yeah, this one makes sense more than the previous. If I have female with joint pain, although it's not there, so but I can say this is young female with some autoimmune manifestation, so I can suspect pleurisy as, for example, lupus or whatever this is. Okay, what else as a differential? I have chest pain, more with exertion nowadays to the wrist or while resting. What do you think? You are talking about hypercoagulable state still. So pulmonary embolism or
You can think of
coronary artery disease or
some
acute
Acute
coronary.
coronary artery disease, yes.
yeah, acute chest syndrome. Whenever I have hypercoagulable state, so it might be in the coronaries as well as in the pulmonaries, right? So I can say acute chest syndrome or coronary artery disease.
I think also need to ask about if there's any family history of sudden death, family history of the heart disease.
Yeah, so also can make sense to add this question about family history of any clotting or heart disease. You can ask about this question, especially if you have palpitation. By the way, palpitation either like arrhythmia, still it's arrhythmia, right? Palpitation or tachycardia, sinus tachycardia, still one of the arrhythmia types. So either related to pulmonary embolism or to the heart, or hemodynamics instability like shock or fever, right? Still, the palpitation, a hint for ongoing cardiac element, for example, or chest. So don't overlook it. It's very important positive finding in the history and examination. You have to examine the pulse itself. Is it regular or irregular? And the radio-radial, synchrony, and radio-femoral if you have time. The good thing you ask about the posture hypotension. ECG, you put it in your investigation, right? ECG, cardiac enzymes, I heard about it. Cardiac enzymes, BMB, troponin, all of them are important to mention. Okay. What's important in the history if you suspect pulmonary embolism regarding the investigation? Dr. Sen?
We'll do the D dimer first of all.
Oh, okay,
Uh,
perfect. D dimer. If D dimer is positive, what you have to do?
we'll do a Doppler ultrasound of the leg veins, and then we'll do a CTPA.
Okay, so what you have to do before deciding for CTPA?
We can do a bedside echocardiography to look for right RARV dilation.
Okay, what's important in the history? You didn't get my question. What's important in the history to ask if I'm going to do chest X-ray or CTPA in a
Pregnancy
female?
history.
Yeah, pregnancy, which he didn't ask, right? It's very important one, and it might harm in the welfare maintenance, right?
If I ask
In
the last menstrual period, so that should rule out
perfect.
pregnancy.
Okay, so you are you ask about period. Okay, but I'm just repeating them. Maybe it will be missed
Yes.
by any other candidate. Then, okay, we are done with the clinical differential. Yes, it's a good mark. If you mention, no, it will be borderline if you didn't mention what I said. So it's not sensible to put the pneumothorax in this patient. You have other condition, you can put it as a differential. The next concern, you maintain the concern, right? And the welfare also was maintained. So I think, yeah, so you can get, I will write the judgment related to the skill, every skill. You can find it in the chat box. Any question, Dr. Sen?
No, no.
Okay,
So, to
yeah,
be very frank, I've never come across PNH, how it presents and all. So, I've never seen somebody with a PNH in my life. So, when you do not see something in our life, so it doesn't stuck. So, and most importantly, in somebody with a history of pulmonary embolism, and there is no
yeah.
physical finding at all. Giving differentials becomes always very, very difficult,
By the way,
and there is no physical
in some
finding.
center, yeah, sorry to interrupt. In some centers, sometimes they bring surrogate without any finding.
Yeah. So,
How they can judge? They will judge on your physical examination, right?
mm, mm.
Yeah, continue. What you were saying? Sorry, I interrupted you.
No, no, that's fine.
Okay. Any other part you want to clarify in this history? The question now for Dr. Rasha. What
Yes,
is
but
the
I want to ask
exact?
why this patient is important portal hypotension. The pulmonary embolism is not related to the portal hypotension.
No, no. If you suspect palpitation related to anemia, so you can ask about it, right?
Yes, but regarding this case is not need for portal hypotension.
Uh,
Yes.
it's not okay. It's not related. Maybe it's not directly related, but as I said, maybe with the palpitation you can offer it. It's okay. If not, it will not harm your mark. If you ask it, it's not a. The examiner will tell you no need or skip it, but it's okay. Not necessarily to ask it. Right, you're right.
Mm.
So, what is the exact cause of this chest pain, or just put it for differential, Dr. Rasha? What is
Yes,
the
what?
exact? What
Chest
is the
pain,
exact? Yeah.
pulmonary embolism.
Okay, pulmonary embolism because of polycythemia rubra vera,
Because
PCV,
BNH.
BNH. Okay, perfect.
Mm.
So the most important question to pick up the finding as BNH is not about the color, about the timing itself.
The timing, yes.
Yeah. So
Yes, because this case is previous before الكانت
yes,
problem in timing
exactly.
الurine, yes.
Yeah. So it's not important to ask about uh, what exactly during the stream. You want to ask about the timing of the occurrence if you suspect hypercoagulable state. What you are asking, Dr. Sen, regarding the stream of the urine, when exactly this dark or the hematuria, if you suspect glomerulonephritis. So the patient will tell you all over the stream I have blood. But this is not blood, it was redness or dark urine. which is happening early morning. And by the way, you have family history in this condition. It's positive family history, autosomal dominant. PNH runs in family. So you
Mm.
can ask in particular any family history of the same condition. Supposed to be positive. Same condition while taking this in particular history. I mean the PNH or the redness of the urine. So you can ask here, you have any history of this condition in your father or mother, or in your family. Supposed to be positive, as I said. Okay. Any question else, Dr. Sen or Dr. Rasha?
No, no, thank you, thank you.
Okay, Dr. Sen, well done. Again,
Mm.
your approach just to be organized. I will send you my approach and I will send it to the group again. It's a systematic one, but if you have favorable one, it's okay. But I believe this one, I will send it, the algorithm I put and I made myself, organized. If you follow it, you will pick up most of the finding. You will look to the examiner that you are systematic and organized. Okay. Just try, I will send it to you. Just try to train on it if you don't have another approach or scheme. If you have, it's okay. But I want you to be more systematic in your system review or in the history taking. Otherwise, you have good confidence, you have good knowledge, good differential. You can get good mark. Okay. Any other question, Dr. Rasha or Dr. Sen?
No, thank you.
No, thank you, thank you.
Let's go to the comments, or anyone want to comment before starting reading the comments? Dr. Inas said pulmonary embolism, pericarditis, pneumothorax, musculoskeletal, acute cold syndrome, pneumonia. Yes, almost you get it. You get it. Yeah, pulmonary embolism in the top of them. Pulmonary embolism also Dr. Realme, Note, PEACS, pericarditis, AD, pneumothorax,
But
past
I think,
case.
Dr. Basim,
Yes,
Dr. The problem here is not about pulmonary embolism. What is the underlying cause behind the
exactly.
pulmonary?
Yes,
Because pulmonary embolism from the chest pain, if you a young female patient with chest pain,
yes,
and after that, maybe most of us, he put the pulmonary embolism in the top of
yes.
differential. But what you need in such case, just pain everyone he knows how to analysis. But I think Dr. Sam, when he ask another many question and everything from surrogate, no, he feel hesitant and lost. That is why. So be calm, concentrate, be systematic. You will not be
Mhm.
directed here or here. So if you, the young patient, if you exclude the cardiac pain, no history or family history of heart disease, not diabetic, not hypertensive, not high cholesterol. This is cardiac to the one side. Then with respiratory symptoms, shortness of breath and chest pain, if you with pulmonary embolism in young patient, so you need to roll out very the thrombophilia risk factors. So
Mhm.
if you go to through these causes of thrombophilia, definitely you will find one cause like paroxysmal nocturnal hemoglobinuria, or Bastard disease, or malignancy, or antiphospholipid syndrome, whatever the cause. So just single message, if you go systematic, even if you did
Yes,
not catch the diagnosis, because a lot of us, if he did not catch the diagnosis, he will be hesitant. He will feel just he's lost in the middle of the road. That is what I felt to Dr. Sen at the middle. Because when he mentioned at the end differential diagnosis, for example, pneumothorax, that means it reflects
yes,
that he lost, because
yes,
if whatever you mention something in differential diagnosis, you will augment that in the history and examination wisely.
exactly. Yes,
The finding. So that
yeah.
you will build, you will not say some other. When you say
Yes,
differential diagnosis, you will say differential diagnosis in
with
your
evidence.
scenario based on
Exactly.
your history and your
Yes,
examination and the
yes,
finding, I mean. But he's so confident. To be honest, he's so confident in the asking question, and he's so fluent.
yes. Perfect. This is the same comment what I meant earlier. The examiner want sensible differential, not only to give a differential. So whenever you are giving, yeah, we have a list of differential. Here, can I say it's musculoskeletal? No, I cannot say it as a differential. If I want just to fulfill the differential list, I can put a lot of differential. But what the examiners want, the sensible one. Why I'm saying pulmonary embolism on top of my differential? Because I have history of red urine based on the history, family history, PNH, one of the possibility. In this way, I can say this is pulmonary embolism with underlying PNH. What could be others? Okay, again, thrombophilia. It can be as association with blood clot to the coronaries, and I can say acute coronary syndrome. What else? It could be anemia. Anemia also can cause chest pain, and it can cause also because of the anemia also related to my underlying diagnosis. Please, not only to say any differential, put the sensible one. Yes, before entering the station, you can write a lot of differential. While you are taking history, you can roll out or you roll in what is the most sensible one during taking history. Okay. Quickly, I will read the comment. Yes. What is the important? Okay. Paroxysmal nocturnal hemoglobinuria. Yes, Dr. Salma. She got the case. Female history. Exactly. In particular, miscarriage. I think I couldn't hear it. Is there a specific time to read urine perfect? This is the most target question. I want to know what exact time of being dark urine. He will tell you, doctor, I notice my urine get dark at the morning. So this is the evidence of my hemolysis, which is happening nocturnal. Nocturnal means overnight. Okay. And the polycythemia, yeah, yes, if I have itchiness, so I can put it, or I have headache. How to pick up the polycythemia whenever I'm taking systemic review from the headache? The first question always in the CNS, do you have headache? Right? It's the more very common headache question in the systemic as a CNS. Do you have headache? Doctor, yes, I have on and off headache. When I analyze the headache, I will try to find out why this patient is having headache. I will find this patient is having, for example, flushing in his face while taking bath, hot bath, or he has a history of clot. He has history of itchiness. After that, I can pick up, but the headache should be justified during taking the systemic U. Of course, along with the complaint. Of course, this patient will present with something else. He will not come as a free patient, and I will try to pick up the finding. Finding of what? He should be presented with something like, for example, itchiness, or he will present with headache, or he will present with history of pulmonary embolism or history of DVT. Then I can pick up this finding later on. Polycythemia, miscarriages, yes, okay. Any other question or comment from others? Anyone want to add any question or to ask any question? Clear for all? Let's recap our cases today. First case was back pain. Patient presented with back pain after fall, minor trauma, with the finding of celiac or related celiac manifestation, which is dose motion, flushable, not flushable one, related to the food on and off, along with the thyroid, vitiligo, and the back pain was also manifested as mechanical back pain associated with the lower limb weakness, and the case was celiac disease, post-trauma, and patient was having osteoporosis. Then it has, or he has, or she has a fracture of the back pain, of the backbone. The second case was about pulmonary embolism, which is present with short of breath, sorry, chest pain over 2 days, along with history of dark urine at the early morning. Otherwise, the history was okay. The examination also was okay. Any question before ending the session? Thank you, Dr. Rasha and Dr. Sen. Thank you,
Thank
everyone.
you.
Dr. Mahjoub as well. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.